Well, thank you all for joining our presentation entitled Emotional, Cognitive, and Behavioral Impacts Following Military Sexual Trauma and Treatment Recommendations. Our presenters today will be myself, Merdijana Kovacevic, as well as Alana Shapiro and Emma Lucas. And we are all clinical providers at the Road Home program. The Road Home program provides assessment and treatment services for veterans dealing with a variety of difficulties, trauma-related, including PTSD, as well as other non-trauma-related difficulties, such as generalized anxiety. And we provide some innovative care that involves providing treatment on a daily basis so that veterans can receive a full dose of an evidence-based treatment, including cognitive processing therapy or the unified protocol, in as little as 1 week or 2 weeks. And so today we'll be sharing about different impacts related to military sexual trauma as we serve veterans who have experienced military sexual trauma. We have specific cohorts that allow them to join us, as well as other veterans. And so we'll be using our insights from our clinical work as well as insights from the literature to provide you with some information today. I am a clinical psychologist, Alana is a social worker, and Emma Lucas is a neuropsychologist. We do not have any financial disclosures to say, and you can receive 1 CE credit for attending this talk, and that information is provided here, and it'll also be shared in the chat, as well as it also can be emailed so that you can get your CE credit for your time. If any questions do come up, please feel free to reach out to Ashton_Kroner at rush.edu, and we can make sure that you get the credit. In terms of our objectives today, we're planning to provide a brief background on military sexual trauma, then jump into providing psychoeducation about how the body responds to military sexual trauma, and then we'll jump into the emotional, behavioral, and cognitive impacts following military sexual trauma, and then we'll wrap things up at the end. Feel free to ask any questions along our presentation or at the end. Would be happy to take them at any time. And so to first provide that background, that brief background about military sexual trauma, military sexual trauma encompasses sexual assault as well as sexual harassment. One definition is that it is psychological trauma which resulted from a physical assault of a sexual nature, battery of a sexual nature, or sexual harassment which occurred while the veteran was serving on active duty for training, or inactive duty training. And sexual harassment has also, one definition for that has been repeated, unsolicited, verbal or physical contact of a sexual nature, which is threatening in character. So MST can include a wide variety of incidences that can involve being physically forced, being pressured, coerced, threatened into sexual activities, or being unable to consent. And what we know in general is that it's pretty prevalent. There's many different studies out there. They use a lot of different ways to measure how frequently it happens. And there's also a lot of underreporting that occurs because of the pressures within the military to not report, and in general, pressures that come up for folks. But some estimates are range between 15% all the way up to 45% of service members and veterans endorsing at least one incident of either sexual assault or sexual harassment. And so this is a really prevalent problem that deserves a lot of attention. And so today what we're hoping to highlight is just some of the impacts that result after experiencing any form of military sexual trauma. And so the first thing we thought that would be really important to highlight is the physiological reactions to sexual assault. And so my colleague Alana will take it from here.
Yeah, I appreciate everyone being here today, and I'm looking forward to talking more about this topic. Essentially, what I'm going to be doing is providing some psychoeducation on how the body responds to MST and trauma, sexual trauma in general. Next slide, please. So essentially, there's this theory called the polyvagal theory. It was founded by Dr. Stephen Porges. It does need further research, and right now it is a theory, so I just want to be transparent with that. Essentially, it's talking about this idea of neuroception and how the nervous system can perceive threat, as well as the nervous system being a way to protect us, to help us survive in horrifying and traumatic experiences. It can also sense cues for safety as well, and that can help us further engage in our social connections. In terms of what our nervous system is kind of broken down to, it can be looked at through the sympathetic nervous system, which is often associated with the fight or flight response, and also the parasympathetic nervous system, which is associated with kind of that like rest and digest state, and the ability for us to connect socially with others. Next slide, please. And so to kind of break this down further, I think this theory explains pretty well how the trauma can stay stuck in the body. And so when we're looking at this primary response, that's often referred to as the freeze response, which is not uncommon to see during an MST. And essentially what this is saying is the body becomes immobile. It's almost like faking death in a way in order to survive this traumatic experience. And I think what's important to note is that the decision for your nervous system to go into this freeze response is made without conscious awareness, and it is made in a way to protect us and help us survive the event. A secondary response, often referred to as fight or flight response, is also very protective in nature. And so, for example, if you're in the middle of the street and you see a car coming, that cortisol is going to increase in your body, and that is what's going to help you survive that experience. And then this tertiary response, again associated with the parasympathetic nervous system, is really called this like rest and digest state. It's when we feel socially connected, that's when we are feeling safe, and ideally where most of our time should be spent unless there is a genuine threat to our safety. And oftentimes with veterans who are diagnosed with PTSD, this is not where a lot of their time is spent. And that's where we see a lot of symptoms of PTSD kind of come up and interfere in their connections and their relationships. Next slide, please. And so again, talking more about this freeze response, because it is often seen in response to MST or any sort of sexual assault. And so this is the response that gets turned on during a life-threatening event. The body shuts down, and it's really as a way to protect us, to survive severe injury and death. This reflex is protective. It helps us increase pain threshold in the moment, and is also associated with psychological disassociation. And what that can look like is often I hear, veterans saying, I was almost like watching the assault happen to myself, versus experiencing it in the moment. And again, that's a survival response. And so we often see that there is this like sense of self-blame or this shame followed by this freeze response. And so because we're not able to physically fight, And so we might blame ourselves. And really, this is just our nervous system trying to help us survive this terrible experience. And so I think what's really important here is that this freeze response is absolutely not correlated with choices or intentions or sexual desires. And it is made without conscious awareness. And so our body is going to decide how the nervous system is going to react in order to best survive the traumatic event. Sometimes the perpetrator may perceive this response as a passive yes, but that's assuming that the perpetrator does not necessarily want to injure the victim, and that is most certainly not always the case. Next slide, please. And so this is outside of the polyvagal theory, but another response that we see emerging in the research is something called this like tendon befriend response. You may have heard it as like the fawn response, people pleasing, and this is often seen in those who have experienced developmental trauma in their childhood. And actually, males who have survived childhood sexual abuse are 50 times more likely to experience MST while in the military. And there's a couple reasons for that. One is that the behaviors that people use to try and survive developmental childhood often carry into adulthood. And that can look like having looser boundaries. It can look like putting other people's needs before your own, which may put people at higher risk for adulthood trauma. And so when we see that children are surviving traumatic experiences, they may use pro-social behaviors as a stress buffer, because we know that physical defense is very much irrelevant because of the power imbalances between the adult and a child. And then again, we might see this self-blame or guilt and shame for how our nervous system response happened during the situation. I mean, we may see inaccurate interpretations of that. This can look like, doing exactly as you're told. It could be offering a belt instead of a knife. And it can also be trying to protect your friends and perhaps siblings as well. Next slide, please. And so you'll see here some reflections from the research on survivors of childhood sexual abuse, and just how profound the interpretations of our nervous system and kind of the outcome of the traumatic event can really produce really intense, painful emotions. And that can also contribute to avoidance, which we know is often something that maintains the cycle and the symptoms of PTSD. And so here we can really see that people do feel ashamed. People do feel the sense of self-blame for how they may have reacted after a traumatic event, even if those beliefs are inaccurate. It may have been formed in a time when they were very scared and they wanted to have that sense of control, versus thinking that we can't necessarily prevent all bad things from happening, because that can also contribute to a lot of anxiety that is hard to manage, and also at the same time possible to manage with treatment. Next slide, please. All right, and so what can we do? How can we incorporate this theory into our practice to help our clients and to help veterans gain a different perspective of the MST that they've survived? Next slide, please. And so we often see, as part of a symptom of PTSD, these inaccurate beliefs as a result of the MST. And often that stems from our nervous system response to the traumatic event. And we know that trauma can either shatter our basic belief system about ourselves, other people, or the world, or perhaps reinforce it, which is more commonly seen when those people have developmental trauma before adulthood trauma or before an MST. And those who are in that freeze state are at an increased likelihood to be diagnosed with PTSD. And a lot of that is based on the shame and the self-blame related to the response of the nervous system during the time of the event. We often see beliefs like, I am weak, I am bad, I should have fought back. If I had fought back, then the event would not have happened. And we know that really that was our nervous system protecting us. And if we did fight back, the outcome could have even been worse. And so a lot of these inaccurate beliefs contribute to really intense and distressing emotions. And that can also lead to avoidance, which does interfere with recovery from PTSD. And so exploring these beliefs and being able to recognize a more balanced way of thinking about the trauma may help accept the event and help us move forward in recovery as well. Next slide, please. So in terms of like, how can we help in the treatment setting? Creating safety in a clinical setting is key. This idea of neuroception is saying that, we can sense things like subtle eye movements, posture, breathing, and that all can be interpreted as safety signals, and can help activate that parasympathetic nervous system to help us engage in treatment and trauma process. We also, I think, have this tendency to frame resistant behaviors like avoidance, not completing homework or practice assignments, being silent in the session, as treatment interfering. And while they can be, we can also look at it as a strength and as a way for veterans and other clients to protect themselves if they are not feeling safe in that environment. And we also find that providing psychoeducation on polyvagal theory may help to decrease some of that self-blame and also increase the likelihood for engagement in treatment. It helps with the therapeutic alliance. And when we honor and validate these protective mechanisms and these survival skills, and when we're in all of them, I think that can really help to build rapport between provider and the client. Additionally, the provider's ability to kind of like self-regulate and get into their own parasympathetic nervous system can really help to co-regulate with a client who may be rightfully so in distress. And, people can sense when we're not fully present during an intimate conversation, and that can feel very painful and very rejecting. And that place of safety really comes from a place of being genuine. And again, like, this is where self-care and self-preservation of the provider is just so vital. Next slide, please. So with all of this being said, in terms of treatment recommendations, I think that psychoeducation is vital. Really normalizing these psychological reactions and physiological reactions during or after a sexual trauma can really help to decrease that self-blame, which can be very profound and detrimental to the survivor. And really framing these physiological reactions or the nervous system reactions to trauma as functional, adaptive, biological, ones that have helped them survive such horrible experiences. And there's a reason that, why not saying no is not saying yes. And again, that goes back to that freeze response. I would also encourage regular check-ins throughout the session to further normalize these protective reactions in order to create moments of engagement. Often, checking in to see if the conversation is becoming too much, or if it's in the challenge spot, or if it's in the calm spot. And so if it's too much, it may be appropriate to kind of regather ourselves and do some grounding skills. And then I would also leave with this and being super affirmative, because this is some of the hardest work that our clients might do in their whole life. And really just saying, like, you are doing a great job with this. You are doing a great job sitting with these really hard emotions, I think can go a really far way in their own treatment, in their self-efficacy, and also in the relationship that they have with their provider. Next slide, please. Thank you.
Thank you so much, Alana, for setting the stage to help us understand how MST survivors' response after a trauma can impact them, and how that response that they have after, whether it's the freeze or the tend or befriend one, or any other response, can come up in their daily life weeks, years after the traumas have occurred. And as that response is being triggered for a variety of different reasons, it can lead to them feeling distress, strong emotions, and then using different coping responses to deal with that. And some may be helpful in the short term, some may be not so helpful in the long run. And oftentimes that leads to further emotional and behavioral impacts that I'll be talking about today. I've used some systematic reviews to try to narrow in some of the most common impacts. Of course, this is not comprehensive, but throughout my presentation, I'll also highlight some quotes from the voices of military sexual trauma survivors that was conducted in a qualitative study in 2023 from 23 different veterans. And their voices reflect what we're also seeing in those systematic reviews that are conducted with larger samples. And so one impact that Alana has highlighted are trauma-related difficulties, such as post-traumatic stress disorder. And so oftentimes military sexual trauma survivors may experience memories and triggers that intrude upon their life. They may avoid people, places, situations, thoughts, emotions that remind them of the trauma. They may experience negative beliefs about themselves, other people in the world, have strong emotions that come up that are triggered by different things, including shame, guilt, and they may also have a physiological response that gets activated, such as being very hypervigilant to different situations or having a hard time sleeping. And so this can come about in many different ways. There's no one way that these symptoms show up, and that can be confusing to diagnose, especially in the early stages of experiencing these difficulties. Since the symptoms are so wide-ranging, it can be hard for survivors to recognize that they are having difficulties, especially since that avoidance may be keeping them from being able to see those impacts. What we also know is that after experiencing military sexual trauma, PTSD is not the only negative impact. And oftentimes, if someone has post-traumatic stress disorder, they oftentimes have a co-occurring condition. And so I'll highlight some of those. Some of these, again, can be standalone conditions or can co-occur. with trauma or PTSD. But all of these difficulties either are exacerbated after trauma or initially start after a trauma and then continue to escalate as the individual is trying to figure out how to cope with all of these symptoms that are coming up for them. And so along with the PTSD specific symptoms, military sexual trauma survivors can struggle with regulating different emotions that come up. One common impact is having symptoms of depression that show up. And as the quotes highlight here, oftentimes military sexual trauma survivors may have decreased mood, as well as a lack of interest in things that they used to enjoy or in their day-to-day activities. So it can impact them in many ways in terms of how they're interacting with others and in their job as well, which I'll talk about a little bit later. They also may experience anxiety-related difficulties, some that may be very consistent with PTSD. And so, for example, they may experience a lot of anxiety related to feeling unsafe in different situations, as is highlighted here, as that may reflect what they experienced during the military sexual trauma or what happened afterward. Other times, for some survivors, anxiety-related difficulties may be separate from the PTSD diagnosis. So they, along with potential anxieties about safety, they may also worry about other things that are occurring day to day that may make them feel very uneasy and unable to interact as they normally would. And to deal with all of these things that are coming up for them, whether it's PTSD, anxiety, depression, or other mood-related symptoms, survivors may find different ways to cope. And so I'll highlight some of these that show up. One impact as a result of military sexual trauma is disordered eating. There's some research to suggest that military sexual trauma survivors are twice as likely to meet criteria for an eating disorder as compared to combat veterans. So it seems to be a prevalent thing, especially for sexual trauma. And I've listed some different ways that disordered eating has been shown for some military sexual trauma survivors, such as starving behaviors, binging, purging, laxative use, overexercise. There's definitely other ways. One study had noted that starving behaviors were particularly prevalent among military sexual trauma survivors. So we need further research as to why that disordered eating behavior comes up. But in general, some of our research is suggesting that these different behaviors are used as a way to manage some of those overwhelming emotions that we had just talked about that come up after experiencing MST. We also know that after experiencing a trauma, any trauma, that survivors can struggle with thoughts about their ability to control their day-to-day activities, as trauma is so unpredictable and can shake up our beliefs about control. And so disordered eating can also be used as a way, potentially as a way to restore those beliefs about control, and at least they can control one aspect of their life. And another reason that disordered eating may come up is that survivors may believe that if they change their shape or weight, that can potentially change the attention that they're getting from others. And so some negative beliefs may come up about their shape and weight and what that means, and some blame about if that caused the trauma or not. And so this relates to some of the inaccurate beliefs or all of these can relate to the inaccurate beliefs that Alana was talking about that can show up after trauma and MST. Along with disordered eating, another behavior that can come up for some veterans is suicidal behavior, as well as ideation. And as this quote indicates, MST survivors may start to feel hopeless and not be able to see ways of being able to manage all of these different symptoms that are coming at them at once. And so they can feel very overwhelmed by that experience. Along with suicide-related behaviors, another common difficulty that can come up is related to substance use. And so this comes up for a variety of different traumas where survivors may use alcohol or other substances to block things that are coming up for them. So if they are experiencing some of those anxious thoughts that are coming up for them and they don't know how to manage them, they may try to use alcohol or other substances to suppress all of these different things that are coming up for them because they don't know what else to do to be able to cope. Another area that gets disrupted for MST survivors is related to their sexual health. So we definitely need more research related to this, but clinically and from some of the few studies that are out there, low sexual desire, arousal, and satisfaction has been documented for MST survivors. They may find themselves withdrawing from sexual behaviors of any form because it may trigger them in different ways. So because of the way the body responded during the traumatic event, when they encounter other situations that involve intimacy, that response that showed up in the traumatic event may show up again in this new experience, even if it does not resemble the trauma. So for example, if they experience the freeze response during the trauma, even when they're, with someone that they may care about and want to have sexual relations with, they may find themselves getting into that freeze response automatically and then not being able to know how to manage that and then withdrawing at that point. Along with withdrawing, on the other spectrum, some MST survivors may engage in more risky sexual behaviors for a variety of different reasons. So this spans many different areas and ways that sexual health can be disrupted. And at the end, I'll provide our next talk or the date of our next talk, which will help us to understand how pelvic health gets disrupted or gets impacted as a result of MST. So you can get more information in this area since it is so important. And as survivors are experiencing really a wide range of symptoms, it does impact their functioning in a variety of different ways. So I've highlighted a few that we definitely see. One is in terms of interruptions and how they're interacting with other people. They may have a harder time trusting others, people that they knew and new people, and they may have difficulties interacting with civilians, partly related to the difficulties with trust, and then partly related to differences in terms of culture, in terms of military culture versus non-military culture. And then there's also, if they're avoiding people as part of PTSD or their anxiety or depression, then it may make it challenging on that front as well. And they may also note that they don't feel as good about themselves. And so they may find themselves in general withdrawing from others. Along with changes with their interactions with other people, an obvious interruption is also changes in the workplace. Since military sexual trauma, by definition, occurs within their institution, within the military, while they're employed in some way or affiliated with the military, it definitely has an impact there. So some of the ways that it could get impacted is that they may have to change their career within the military. This may be initiated by their own volition or more so to get away from, either the perpetrator or the triggers, the symptoms that they're experiencing when they're near the areas that they may have been assaulted at. Or this change in career may be initiated by the military where they may be moved around. And because of some of the symptoms that we've been talking about, like the difficulties concentrating, the anxiety, and all of these other things that may be coming up, it can also be harder to do the job in the same way. So they may have a harder time completing tasks because they may have a harder time managing these symptoms that are coming up. And along with these, a wide range of symptoms that really negatively impact trauma survivors' lives. I also wanted to spend a little bit of time just highlighting that there can be some growth after trauma. And one thing that I'll highlight is that some MST survivors note that they continue to fight. And a big piece of military culture is that fighter attitude. And so even though they've experienced this horrible event in this institution, this cultural piece of continuing to be a fighter may show up afterwards and allow them to continue to move towards recovery, even though it may be very challenging. Another way that they may grow is just in terms of how they relate to especially other military sexual trauma survivors or other sexual assault survivors. They may want to pass on information to others in an attempt to advocate because of the impact that they know that it's had on them, and for a variety of other reasons. And so I've highlighted some of the impacts the behavioral and emotional impacts. Of course, this is not comprehensive, but it can get us started to think about what kinds of things we can do on the assessment front and the treatment front. So first, I'll briefly touch on some assessment recommendations. So since the symptoms that I've talked about are really wide-ranging, it's really important to assess very comprehensively trauma history, as well as a variety of different symptoms and areas of functioning, and to figure out, how are these symptoms related to a veteran's traumatic events. So you can really clearly indicate what's at the root of their problems. And also not forget about how military sexual trauma does impact, or usually impacts, their careers, just by definition that it's occurring within the military. So there is going to be some shift, whether it's in terms of how they're feeling in that environment or, needing to be moved somewhere else. So important to assess that as well and see if they need additional referrals or if you can provide those services. Along with these recommendations about very comprehensive assessments, we also recommend having a trauma-informed multidisciplinary team that can provide services for MST survivors. So we encourage a wide range of specialists, since the symptoms are so wide-ranging. Within our Road Home program, we actually are a trauma-informed multidisciplinary team. And so we have social workers, psychologists, neuropsychologists, art therapists, medical specialists, chaplains, peer support specialists. And we also know that career is important and other components are important. So we also make sure to refer veterans even beyond our team to others who may have specialists in career counseling or other areas that can try to get at all the wide-ranging symptoms that come up. And since MST survivors are from diverse backgrounds, it's really important that the team continues to work on cultural humility. And so the way we address that is by doing our own presentations in-house on different important trauma-related concerns and relate them to diversity. And we also hire other specialists who are able to provide more in-depth trainings on how we can improve on D&I efforts. We also really recommend veteran-centered care, or person-centered care, where we're really acknowledging, what is at the root of their symptoms. Sometimes, when someone may come in with, for instance, like substance use issues, we may want to immediately work on that, but at the root, There may be all of this trauma that they've experienced that they've never really talked about, and they may be using things like substances or different eating habits to cope with all of these other trauma-related symptoms. So we just encourage providers to really consider what may be at the root of their difficulties and to help them focus in on that. As part of our program, one of our programs focuses in on using cognitive processing therapy, which allows us really to tackle how MST has impacted how they view themselves, other people, and the world. And we also recommend that throughout both assessment and treatment that we're really considering the voice of the veterans, since they may have experienced negative reactions after they experience the MST for a variety of reasons. And so it's even more important to make sure that their voices are being heard and that we are providing care that is not one size fits all. And so one of the things that we do within our program is we do provide that treatment on once per day or twice per day. They receive cognitive processing therapy for 2 weeks. So they receive a total of 17 CPT sessions in 2 weeks. And we give them assessments throughout their time here, and especially at the end, where we continue to collect their opinions about how their stay was and what we can do to improve. And then we use that information to continue to improve our programming and to improve our care overall. And what we found is that a lot of veterans indicate satisfaction. And I think that's partly because we're continuing to collect this information and trying to take that feedback in and make any adjustments as we need to. And so I'll be taking a look at the questions right now, but I'll go ahead and let my colleague Emma talk a little bit about the cognitive impacts to sexual assault, and then I'll make sure that the questions are answered after her section.
Thank you, Merdijana. So I just want to thank everyone for your time today and joining our presentation. And I'm here to just add a little bit in terms of cognitive functioning and how it may relate to survivors of MST. So trauma and stressor-related disorders are serious mental health conditions, and they may have associated cognitive functioning problems with them. And the interactions between emotion, physical experiences, and cognition contribute to the symptoms of these mental health conditions, as we've already heard. And cognitive models of PTSD suggest there's a trade-off, or there may be a trade-off in cognitive functions. For example, emotional information that's not related to the primary task that an individual is engaging in may slow the processing of a goal-directed activity and interfere with memory and learning of neutral information. There also may be weaknesses in cognitive control and emotion regulation that can strengthen the impact of emotion on cognitive function. And studies have suggested that cognitive complaints may present as a concern for veterans who have experienced MST. In a study by McManus et al. In 2018, they found that in a small sample of US veterans who experienced MST, 48% of them reported significant cognitive complaints. And in a population-based survey of veterans conducted by Nichter et al. In 2022, male survivors of MST reported significant declines in current mental, physical, and cognitive functioning related to those without a history of MST. Next slide, please. So although we will not be focusing on traumatic brain injuries or TBIs, during this specific presentation, I do think it is important to be aware of the relationship between MST and TBI. For example, the relationship between intimate partner violence, or IPV, excuse me, is well documented in the general population. And TBIs may also occur during sexual assaults. However, sexual assault may be an under-recognized cause of TBI in the general population and among individuals who have experienced MST. So let's take a closer look at IPV-related TBI. A research study conducted by Iverson and Pagoda in 2015 revealed that among a sample of female veterans, 18.8% met criteria for IPV-related TBI, 85% of which reported losing consciousness, and 13.6% reported an IPV-related head event without TBI. In another study by Iverson et al. In 2019, the researchers proposed the need for screening for TBI among IPV survivors due to the associated persistent symptoms and possibility of worse future health, including difficulty with sleep, mental, and physical health. Next slide. So research has shown that PTSD is associated with cognitive deficits, particularly in the domains of attention, memory, and executive functioning, and information processing speed. Although there are evidence-based treatments that treat PTSD, most of these treatments do not affect or hone in on neurocognitive functions, with the exception of maybe memory. Cognitive abilities or thinking abilities include what you see here on this slide. So aside from the ones that I've mentioned, there's also language, visuoperceptual, visuospatial, and visuoconstructional abilities, and sensory motor abilities. So we're going to focus again specifically on the areas of attention, learning and memory, and executive functions, as these areas are often the ones that are reported as areas of concerns with the veterans with whom we work. So attention, just as an overview, is an area of cognitive functioning that impacts all other cognitive functions and is the ability to focus and concentrate on relevant stimuli in our environment. Learning involves taking in new information, synthesizing the information, and integrating it with prior knowledge, while memory involves encoding, storing, and retrieving information. And executive functions are a set of cognitive processes and skills that facilitate self-control and help us manage behaviors. And these skills may include self-control, working memory, and mental flexibility. Next slide, please. So the question is, do cognitive abilities matter in treatment? And I may be a bit biased, but I say yes, they do. And that's what I'm hoping to kind of encourage today, is how can cognitive strategies, compensatory strategies be incorporated in treatment if an individual that you're treating who has experienced MST expresses concerns in those areas. And so cognitive functioning can play a role in the development and maintenance or even exacerbation of PTSD symptoms. And in fact, all psychiatric disorders are brain disorders with some component of cognitive abilities that are likely affected. So addressing cognitive functioning during treatment may possibly optimize your time in treatment. It may improve adherence to the treatment goals and the homework you're assigning and things like that. It may also offer opportunities for individuals to practice the skills in the treatment environment. And it provides the opportunity to improve an individual's daily functioning in terms of areas like school achievement or employment, relationships, financial stability. It may help them improve their health and just in general, their overall quality of life. Next slide, please. So the truth is that most of us benefit from the use of cognitive strategies to optimize our daily functioning, whether or not we have a mental health condition or a cognitive condition. Compensatory strategies are used to help individuals learn tasks or perform tasks in general in an alternative manner or by using adaptive aids so that they can be more independent in the tasks that they're wanting to complete. The strategies help to compensate for a deficit or a weakness or an injury or even a perceived weakness that the individual may have in a specific area. They're not dependent on the cause of the cognitive impairment. So for example, whether the impairment's due to attention deficit hyperactivity disorder or a mood problem or an acquired brain injury. And research has shown that compensatory strategies help with cognitive impairments and they potentially provoke brain plasticity. And so they are stretching our brain in different ways and can help in that way. Next slide. So treatment offers an opportunity to teach, practice, and normalize the use of compensatory strategies. Treatment providers can focus on linking the strategies to the individual's goals and their daily functioning. And I think similar to the previous areas that we've talked about during this presentation, a lot of this starts in the assessment period. So asking the individual if they're having any difficulties with thinking or in their thinking abilities, and really honing in maybe on areas like attention or learning or memory or even executive functioning. And then you can define the goals, incorporating some of these strategies within those and link the cognitive strategies to the treatment goals and the functional outcomes. So now we're going to move into a review of the strategies that you may want to consider implementing during treatment. Next slide, please. In the first area, we're going to review attention. And so I've sectioned it off into 4 areas here. The first one is increasing one's ability to stay focused. And so this may include reducing multitasking. We're actually not very good at multitasking. And so I think debunking that myth for individuals, first and foremost, can be really helpful. And secondly, helping them maybe think through processes of how they can focus on one thing at a time and how they would schedule that out or what that would look like in their day-to-day life. Second one is breaking larger tasks down into smaller tasks. When we see a large task or a large project in front of us, a lot of times it can create avoidance, it may create overwhelm, and it may encourage the tendency to procrastinate. And so having a conversation with individuals about that and how they can break it down into smaller tasks so that they can achieve a goal or complete a project can be really beneficial. The next one is reducing distractions. And so these are distractions in the external environment, but also a lot of the work that you may be doing in treatment may be how to reduce distractions in their internal environment. And one of the ways of doing this, if you look down at the bottom of this, may be encouraging mindfulness or grounding strategies, breathing techniques, things like that, or observing the thoughts that are going through their mind at any one time so that they can, use some methods so that they can refocus on the task in front of them. The last one here is eye contact. And so just encouraging individuals to work towards having eye contact when they're speaking with individuals so that they can maintain focus. The next one is managing their energy. So the first one I have here is eating the frog. I don't know if you've heard that phrase before, but that's basically putting the most difficult task up at the top of the day so you can knock it out before you move into other tasks of the day. The second one is the Pomodoro technique, or this, another way of describing this is timed breaks. So the Pomodoro technique is really honed in on working in a focused manner for 25 minutes and then taking a 5-minute break. And then working in a focused manner for 25 minutes and then taking a 5-minute break. It allows an individual to, keep that focus in mind so that they can complete the task and maybe even creating a goal of what they're going to do in those first 25 minutes, the second 25 minutes, but then they also have a break that they can look forward to. Some people will even extend this time to 50 minutes of focus time and 10-minute break. The next one is scheduling important tasks. So that kind of falls into some organizational strategies as well. So if it's an important task, make sure it's on your schedule. And then also using relaxation techniques. For mental strategies, in terms of attention, sometimes people will tell me that they lose track of conversations or are not able to follow conversations very easily. And so this is where I think the practicing of some of these methods within the treatment setting can be really helpful, because individuals will express that they are embarrassed to ask people to repeat, or they're embarrassed that they've dropped a conversation or didn't hear the conversation. And so being able to practice the process of repeating. I'm sorry, I think I may have missed a piece of what you were saying. Do you mind repeating what you said so that I can make sure that I'm understanding and hearing you correctly? Another way you can use mental strategies for attention is to make associations to the information that people are giving you, or chunking information. So if information is if it's too much information to take in at one time, then practicing the chunking method where you're taking pieces of information in at a time so that you can attend to those chunks and then take the information in more efficiently. Next slide, please.
Emma, before we move on to the next slide, Katrina asked that you had mentioned eye contact, and she said oftentimes clients don't maintain eye contact. Would it be appropriate to ask them to? Thanks for your question, Katrina.
That's a great question. And I think there's going to be different factors that fall into that. I'm so glad you asked that question. So it could be that the first thing I'm thinking of is cultural factors and whether it's culturally appropriate to encourage long spaces of eye contact. The other piece is, and I think when I'm thinking of eye contact here, I'm thinking if someone is not paying attention in a conversation and they're not able to track, it may help them to boost that strategy so that they're able to take in the information more easily. I think it would involve more conversation and be specific to the individual in terms of why eye contact might not be maintained and whether it would be beneficial for them. Not all of these strategies are going to work well for someone, but if you think that there's an area where eye contact may benefit them, then I would encourage that. Does that help clarify? Okay. Please enter in the chat if there's additional questions. Okay. So the next area is memory. And so memory has 3 stages. There's the encoding stage, the storage stage, and then there's the retrieval stage. Most of our strategies focus on the 2 end stages, the encoding stage and the retrieval stage. So encoding is really leaning into some of the strategies that we reviewed earlier in attention. So repetition and paraphrasing, associations, chunking or categorizing. People can also use mnemonics. Mnemonics can be very helpful for us in remembering information. Visualization or imagery can be really helpful for people to remember information. So for example, I am very spatially oriented in my mind. So if someone asks me where something is in the drawer in the kitchen, I can tell them exactly where it's located because I know spatially where things are at. So I use a lot of imagery to try and remember things like that, or visualization. And then overlearning. So not taking the information in only once, but doing it multiple times so that you are getting to a point of overlearning. And then for retrieval, it's using cues. Cues can be very helpful for us, and many of us use them. So things like alarms, using checklists, and also cueing tools like a pillbox if an individual forgets their medications. And then for prospective memory, thinking about things that you will need to remember in the future. One of the things that we encourage for people who are losing their keys or misplacing their phone in their home is to have a designated place. Where is that one spot when you come home, you can place your keys and your phone every single day so that you know when you need to leave in the morning and you're crunched for time, you know exactly where to go to pick those up. And then the other ones would be any organizational systems. So calendars, to-do lists, and using voice memos. A lot of people enjoy using voice memos now since it's so easy on our phones. Next slide, please. For executive functioning, I just have a couple of highlights here in terms of executive functioning. One may be initiation, so getting started on the task. And so some ways that you can encourage individuals to initiate on tasks is to create routines, to create schedules around when they're going to do these tasks, using alarms. Also, visual reminders can be helpful. So I may work with someone and mention to them that I want them to practice mindfulness. And because there's not a visual reminder for them, they may forget to practice it. So then at the next session, we're talking about, okay, what visual cue can we put in place next to your bed, in the kitchen, next to your coffee in the morning to help you remember to practice the mindfulness. And so visual reminders can be very helpful. And then self-monitoring can be really helpful. How can you kind of check in and think about your thinking throughout the day? Am I doing what I should be doing right now? What should I be focusing on? And kind of encouraging that practice throughout the day for folks who may lose track of what they're supposed to be doing throughout the day or what tasks they should be working on. And then any forms of planning and organization systems people can put in place is typically very helpful. And so there's electronic versions of organization systems that we can use, and there's also paper-based, which are absolutely useful as well. Next slide, please. So then the last pieces here are just additional strategies to think of for improving cognition. And the first one is self-care. And so, you know, I think part of that is the importance of not putting, you know, making sure that individuals are doing the things they need to do to take care of themselves and their brain health. So for example, diet and exercise are very important for our brain health, not just our physical health, but also our brain. There is a phrase, what's good for the heart is good for the brain. And that's because our brain has a very involved vasculature system that kind of feeds it. And so we want to make sure that we're doing those things that are healthy for our heart and brain. So diet and exercise, doing some kind of like learning new activities is really good for us. So maybe learning a new skill or learning a new recipe, learning a new language. Those are all really helpful for our brain because it's tapping into that idea of plasticity and really firing off new neurons for us. And then the last one is social engagement. Social engagement is very helpful for our brain health as well. And then I always encourage habits and routines for people because those reduce the cognitive burden on us for remembering things. So for example, if there is a task that you need to do on a daily basis and it happens at a specific time. So for example, taking the trash out at 6 o'clock every Tuesday, and it's something that's forgotten, it's not something that's easy to remember, then setting an alarm to help one remember that task can reduce the cognitive burden and help aid. It's one of those aids that can help us as well with memory. So I think the more habits and routines that we can incorporate as well, the better. All right, I'll hand it back to you, Merdijana.
Well, thank you so much, Emma. And thanks for all your questions as well in the group or in the chat. Feel free to ask any additional questions that you may have or any clarifications. We'd be happy to answer them after we talk a little bit more about our final takeaways about what we can do. And based on all this information that we've been talking about, some of our key takeaways are about the importance of psychoeducation, how providing information about the physiological reactions that occur during after sexual trauma, describing that for folks can help to normalize their experience and give them a better understanding of what's happening, as well as talking about these wide-ranging emotional, behavioral, cognitive impacts can also help them to get a better understanding of what's happening for them, and that then can empower them to be able to adjust things or to make attempts to adjust things so they can help themselves to live the kind of life they want. And in terms of specific treatment formats, we do recommend a trauma-informed, multidisciplinary, patient-centered approach that allows us to also practice cultural humility and continue to work on it, and that allows us to incorporate evidence-based strategies that are consistent with what the client is bringing in, what kinds of goals they have, and considering different factors that could impact their engagement in treatment and in their lives. So like Emma was talking about, the importance of adding compensatory strategies if they're experiencing those cognitive difficulties. That's not only going to help them in their lives, but also if you're doing a certain treatment, adding some of those strategies into the treatment can then also potentially have an impact on how much they can get from the other treatments that they're engaged in. So those are our general takeaways. Here are references. And again, if you have any questions about the program or getting your CEs or access to the presentation or anything like that, feel free to contact ashton_kroner@rush.edu. And then I also wanted to plug our last talk as part of the series on April 28th. That's where we'll really be able to dive into pelvic health. And that talk is also at 12 p.m. Central Time. And so I'll put this slide back up about if you have any questions about our program or the CEs or the recordings or anything that you may need. I'll leave this up, and then I'll also give folks a few more minutes to see if they had any other questions that came up or any clarifications that we can provide about any of our slides or information. And thank you all for attending this talk. And feel free, if you do have a question, feel free to unmute yourself or type your question in. Thank you, Paula, for providing that that information about the client that seems like attended our program. So that's very meaningful to us that they got benefit. We do work with Jessica, so I'll make sure to say hello for you.
Thank you.
Well, I'll go ahead and leave it here. Thank you all for attending. And if you do have any questions about our program or again about getting your CE credit, please feel free to contact us. We'd be more than happy to talk with anyone.